All right. Hello, everyone. Thanks so much for joining this webinar or listening in to this presentation from the Our Health 2SLGBTQQIA plus community study. We're going to focus on the COVID-19 findings from this work that we did last year. My name is Nathan Lachowsky, or Nate. I use he, him pronouns. I am a British Ukrainian settler, and I'm calling in today from the Lekwungen territories. This is the lands of the Songhees, Esquimalt, and Wisanish nations on the south part of what's known as Vancouver Island now, or Victoria. I've been living on these territories for the last 8 years and working with the Community-Based Research Center as the research director for the past several years as well. And it's definitely been a journey as we think about our commitments to reconciliation and to decolonizing our work. We've done a lot of work to learn more about Indigenous communities across these territories known as Turtle Island, to learn more about Two-Spirit, during the history of Two-Spirit, where it's come from, during its use and its politics, and really think about how we create more space for working differently and create space for making sure that Two-Spirit folks feel seen in our work. And that's been through a lot of learning and a lot of time and a lot of gratitude I'd like to share from my colleagues, Indigenous colleagues who've helped me on that learning journey. I'm excited to be able to share some of these really early results around COVID-19 from our study. And just in terms of kind of timely call to action and thinking about during the work that we're doing in terms of indigenizing our work, there is a call from CBRC to join in the proclamation and celebration of Two-Spirit and Indigenous LGBTQIA plus folks in terms of the Celebration on Awareness Day on Monday, March 20th. So if you're listening in now or before then, please mark the day in the calendar and think about how you can join. There will be an in-person event on Musqueam, Squamish, and Tsleil-Waututh territories in Vancouver on Monday afternoon. And there's the hashtag 2S Celebration Day that you can join virtually in terms of Monday, March 20th, in a conversations around raising awareness and celebration of Two-Spirit. So for the presentation today, I'm going to just give a really quick background. I think for most of us who are joining and engaged in this work, we don't need a lot of rationale for why we would focus on our communities in terms of COVID-19. Then I'll share a little bit about the methods, how we kind of ran the Our Health study, and then talk through the results, really focusing on kind of who participated, what we learned from the survey that people completed, as well as some of the results from the dry blood spot testing that we gave as an option for participants in the study. And then I'll talk a little bit about how we're translating or mobilizing the knowledge from the study, as well as some of the lessons learned that I think are important as we move forward in working in good ways with our community. The screenshot in the top right is driven from the ASL and LSQ translations that were provided to try and increase accessibility for the study. And I'll talk a little bit more about some of those methods in a second as well. And then in terms of just for process for today, if you've got questions, jot them down. I'm going to go through this presentation and then we'll open it up for questions and conversation and have a chance to kind of hear from you folks what's resonating, what you'd like to hear more, understand more about, or what feedback you have for our team as we continue to do this work. So just in terms of a bit of background, we know that there's been a number of different public health actions to address COVID-19. You can think about physical and social distancing, vaccinations, during closures, group recommendations, size recommendations, et cetera. We all have lived that for the last few years, and I think everyone is acutely aware of the kinds of impacts that has had generally. But there's a number of reasons why we also think that during our specific communities are being uniquely or have been uniquely impacted in terms of this pandemic. So when we talk about this work, we're really talking about the full gamut of Two-Spirit, lesbian, gay, bisexual, trans, queer, questioning, intersex, asexual, and anyone else who's marginalized on the basis of their sexuality or gender. And so we really wanted to have this broad frame. During Our Health is really exciting for CBRC because it was our chance to really work with the full community. And we've received such calls for doing this kind of broad work over the years, especially with our deep-seated roots in terms of HIV and the Sex Now study that focuses on just a portion of our community. So when we think about the kind of why, we position this from the point of view of thinking about stigma and discrimination. So social forces, social factors that really shape the underlying well-being of our communities. And it's those negative social forces that really create inequities or unfairness in terms of our social lives and our health. And so COVID-19 can obviously have direct impacts in terms of perhaps more people in our communities acquire the SARS-CoV-2 virus and during have COVID-19 conditions, but also the indirect impacts in terms of COVID-19. And so the ways in which how public health action to try and limit or control COVID-19 has led to other kind of economic or during mental health impacts of folks in our community. One of the challenges around the response is it really highlighted for many different marginalized communities how little data there is in terms of being able to tell our stories. And so there's a lack of routine collection or reporting of 2SLGBTQ indicators within government data, whether those be public health surveillance systems or surveys that are conducted. And so running Our Health was a chance for us to actually lead a study by and for our community that focused on getting data and an understanding of what happened within our communities. And so the goals were really to think about broadly the impacts of COVID-19 on our wellness as a community, and to also estimate the prevalence, so seroprevalence, meaning the prevalence based on blood of the SARS-CoV-2 virus within our community. And so those are kind of two of the elements that I'm going to drive in terms of sharing results today. So a little bit more about our methods or our approach. So Community-Based Research Center is obviously really focused on community-based research, but we don't do this work alone. And I think that's a really important and critical piece of anything that we do. I get the pleasure and opportunity to be in front of you today sharing results from the study. But really, there's a whole group of folks that we work in partnership with and collaboratively with to try and make these things happen. And so in terms of some of the national partners, the Two Spirits in Motion Society, Enchanté Network, EGAL, and we also work with YouthCo and many other organizations to help plan the study as well as implement it in terms of recruitment. We also were acutely aware of the fact that Our Health was really a chance for us to do work with the full spectrum of our community. And we wanted to make sure that some of the ways in which our staff and academic team show up don't necessarily represent the full spectrum or diversity of our communities. And so we intentionally sought out community advisors from a number of different groups within our Two-Spirit community. We're intersecting with our Two-Spirit and LGBTQ community in order to make sure that those voices were better represented as we thought through our recruitment materials, as we thought through our questionnaire, et cetera. We're also engaging community advisors at this stage now to plan more community-specific knowledge mobilization efforts. And so I think this is something that we really think is important to have embedded and engaged throughout the whole entire study. I do want to just take a moment to kind of give a shout out to some of the community-based research principles that we just published at CBRC. The link to this is at the bottom of the slide. And I know these figures or images are a little bit small to read, but I just wanted to put them all up there. So these are the research principles that really guide our work. This is part of a living document and a living process where we're learning constantly from doing our own work, but also from other communities and other leaders who have done work in this area before. And so if you want to read more about kind of the principles behind or the values that we base our work in, these are really our articulation of doing that. It's an act of transparency. It's an act of kind of community sharing in terms of saying this is the work that we're doing. And during these values are really important and unique to the ways in which CBRC is showing up in our sector and in research in terms of working with our communities. So those principles include access, advancing social justice, balance, bravery and love, community empowerment, centering lived experience, being historically informed and impact-oriented, taking a holistic view of health, and working intergenerationally. And so again, if you want to read more about those principles, we're sharing them through social media on CBRC, but the full document and background is available on our website there at the bottom of the page. So in terms of some of the more nitty-gritty of what this study ended up looking like, this was a cross-sectional online survey, meaning that we did one survey that was open to people who wanted to participate. And so they could self-complete that questionnaire online from a tablet or device of their choosing. And that ran from April 2022 to September 2022. So basically over the summer period of last year. The questionnaire had multiple domains. And so there was demographics and COVID-19 modules, which are kind of the focus of today's presentation. But we also had modules on chronic health conditions, health care and services and access to those, mental health, discrimination, community connection and belonging, sexual health, reproductive health, caregiving, whether that be for children or elderly or dependents within either chosen family or biological family, economic security and some of the impacts, especially that COVID had in that regard, substance use and housing. So it was a really comprehensive survey. Some folks spent well over half an hour in terms of engaging with the questionnaire and the many different questions we wanted to ask. And we're really excited about being able to have a little bit of information about all of these things, because also how these things connect and relate with each other is so important. And sometimes we have studies that have such a deep focus in one particular area. And I think our health has been an opportunity for us to really set a bit of a baseline for our understanding of what these experiences are within our community. And again, how they relate to each other, especially within a COVID context. As I said briefly before, we gave participants who completed the online survey an option to also receive a mail home dry blood spot self-collection kit. And I'll share a little bit more information about that process when we get to the results. For those who are kind of nerdy or want to know a little bit more about the science, what we're actually measuring in the dry blood spot are kind of antibodies of the COVID-19 vaccine, and particular kind of markers that are on related to that. And so we're not necessarily assessing whether someone currently had COVID. It actually gives us a more historic assessment of whether someone had a COVID antibody response, either through vaccination, through naturally acquired infection, or perhaps both. And so again, I'll talk a little bit more about those results later. And then in terms of eligibility, so the who, folks needed to live in Canada, so anywhere across the country. They needed to be part of the 2SLGBTQQIA+ community. They needed to be aged at least 15 years old to do the survey, but be at least 18 if they were going to do the dry blood spot collection. And then the survey was available in English, French, or Spanish. And so these are 3 languages that we've received feedback in terms of wanting to make sure that things are accessible more broadly to more people in our communities. And so we've been doing a lot of work on the kind of multilingual side. And we love to think about how to also engage better in terms of doing some language-specific knowledge translation as well. And then in terms of our efforts, when we recognize that this was a long survey, we recognize that people are taking time out of their day to complete and provide data. And we recognize also that some of these questions are not necessarily easy to answer, and that they're reliving during some of the challenges and hardships that people experienced during COVID. So we wanted to be able to provide at least a modest honoraria to our participants. And so folks who completed the survey received a $10 honoraria. And if they participated in the dry blood spot collection kit, then we would provide them with $20 for that as well. So a little bit more just on the recruitment side. So how did we actually reach out and get to folks? Our community advisors and partners were critical in terms of refining our message, our branding, during our visuals for this study. So you can see here a number of different pictures that kind of depict during a lot of different people within our communities, different ages, during different gender expressions, et cetera. All of these photos are also overlaid with, they might be a bit hard to see in this picture, but also images that relate to COVID and chronic health. And so during kind of playing with a little bit of animation on top of this. And we also during avoided a bit of the traditional rainbow while still trying to keep things during bright and colorful in terms of this. So this was the kind of brands and images that we used in terms of going out on social media, either through CBRC's organization, but also many other organizations in the sector. And so people would post when we sponsored posts. We also worked with some influencers to try and get them to share information about the study. We did some work in terms of news media coverage to try and reach more broadly folks who may not be engaged in existing organizations or social media accounts, and to also think about that in a multilingual sense. And so not just working with the kind of English language media across the country. We had some print media, and so some stories and advertisements in magazines, as well as transit ads. Folks, if they were at Toronto Pride last summer, might have seen some things around some of the TTC stations near the village. And we also worked, as I kind of showed earlier, that screenshot from the ASL videos and the LSQ was done as well, to try and increase accessibility and describe what the survey was, what the dry blood spot component was for deaf and hard of hearing folks. So we opened the survey up over that period, and anyone who wanted to participate could participate. And so we ended up with just over 4,000 people who completed the survey, which is really quite amazing and gives us a large sample and group of people to be able to look at to understand the full range of impacts within our community. So what I'll do now is describe a little bit in terms of who was actually in the study. And so the average age of our participants was about 34 years, and we had a full range from kind of 15 well into past 80 years old. So we had a good range in terms of age. For participants who self-identified as Indigenous, that was 8.4% of our study. And of those Indigenous participants, more than half were Two-Spirit. When we think about the kind of First Nations, Métis, and Inuit groups, 60% of the study was First Nations, about 30% was Métis, and 6.5% were Inuk. And thinking about some of the different measures we had around sex and gender concepts, about a quarter of the sample self-identified as trans, and we didn't define this in any particular way. We let people self-identify to this label. We asked people how they gender identify, and so about 40% of the sample identified as men, about a quarter as women, 20% as non-binary, 10% as genderqueer, 6% explicitly as trans men, 6% as gender fluid, 4% explicitly as trans women, and 3% as agender. For those who are quick in terms of math, you'll see that those numbers also add up to more than 100%. And so we allowed people to choose more than one option, recognizing that during the diversity in the ways in which people identify. We also asked folks about the sex they were assigned at birth, and roughly 50% were assigned female and 50% were assigned male, and 3% of our participants preferred not to answer. That's what the PNA stands for there. And then we also asked a question about intersex. And so again, during this was around self-identification with the term, and 2% or 1 in 50 of the study identified as intersex. In terms of sexual orientation, again, people could select multiple options. 38% of the study identified as gay, about a third as queer, about a quarter as bisexual. Then we had about 14% who were pansexual, 13% as lesbian, 6% as asexual, and then 2% as questioning, 2% as homoflexible, just under 2% as heteroflexible, and 1% as straight identified. So really quite good diversity in terms of sex and gender markers and sexual orientation around our community. And so glad to have been able to reach that. We do see during a smaller proportion of women identified individuals within the study. And I think that's something that we want to continue to work in terms of thinking about visibility, inclusion, and accessibility of the study for women in particular, given kind of our history as an organization and the transitions we're making in terms of trying to serve the entire spectrum of 2SLGBTQ+ folks. And so that's somewhere that I think this was a great first attempt, and we learned lots about doing this work, but there's also much more that we can do on that front. There's a lot of other parts of our community also that we want to think about whether we're serving well and appropriately representing within our studies. And I think this is one of the challenges to some extent around this, is that we also don't really know what would be a fair baseline because we don't have these kinds of questions on representative studies within Canada or things like the census. We have pretty limited data to understand whether folks might be over or underrepresented within our study. For us, what's important is that we speak with and hear from enough people that we can actually provide some stratified or community specific data, because that's often what we get asked for. So just a few more on kind of sociodemographics and thinking about social determinants of health. In terms of ethno-racial identity, 4 to 5 participants identified as white, 6% as East or Southeast Asian, 4% as Latina, Latino, Latinx, or Latin, 3% as Black, 3% as South Asian, and 2% as Middle Eastern. You'll remember I shared the information about Indigenous identity on the last slide. In terms of disability self-identification, over a third of participants said that they self-identified as having a disability or being disabled, which is a pretty significant portion of the study, and something that we certainly want to look at more, particularly in the context of thinking about chronic health and thinking about COVID, the two kind of main focuses of this study overall. And there will be a webinar for those who are interested later this month, sharing some of the more results from the chronic health part of this work. And Adarana Verma has been leading that on our team. In terms of where folks were born, 4 to 5 folks were born in Canada, and then during the majority of the rest of the folks were permanent residents. 2.5% of the study were non-citizens or non-PR, and so had during more precarious legal standing in terms of their ability to stay in Canada. In terms of educational attainment in formal Western systems, just over half of the study had completed a bachelor's degree, 16% had completed high school, and about 1 in 25 participants had not completed high school. And then this figure at the bottom is just meant to show a little bit of the geographic diversity in terms of the study. So about half of the study came from very large urban population centers. So those would be places where there's more than 500,000 people. During about a quarter came from other large urban centers. So from 100,000 to about 500,000. That's like the community of Victoria that I live in here. During 13% came from medium population centers. So this is 30,000 to under 100,000. And about 1 in 10 came from small population centers. This is like the small town of Waterford, where I went to elementary school and grew up. And the rural areas are where there's less than 1,000 people, like the farm that I grew up in Norfolk County. So we have that range of geographies, and we know that COVID was experienced differently, both in terms of access to supports and services, but also in terms of restrictions in daily living based on geography. And this will be something that we want to make sure that we attend to in our future work as well. So let's get into a little bit of some of the actual results that people shared around COVID. We think it's really important to center self-perception and self-reports around health. And so we had this broad question of just how would you rate your overall health now compared to before the pandemic? And so what you can see here is a distribution across the 5 different response options that we provided. Roughly 40% said about the same. And when we think in terms of some people, during 17% of the study, or about 1 in 5, said that they were somewhat or much better now than they were before COVID. And about 40% of people were much or somewhat worse than they were before COVID. And so this speaks to the diversity in which people experience COVID, and also reflects to some extent the fact that we were asking this question kind of 2 years out of the original kind of start of the COVID pandemic, when we think about the kind of timing of the study. So this is a figure that tries to put together a whole bunch of different information about COVID status in terms of self-report, as well as people's testing history. So I'm going to take some time to kind of just walk us through this. I think this is doing a really rich picture of kind of what it has been like for those of us in terms of thinking about COVID. So this blue line in the middle of the figure kind of divides folks in terms of self-report. So let's just start with the bottom part here. And so this below the blue line is roughly 50% or half of the study self-reported being COVID negative. So of that 50%, during 42.6% were people who actually tested negative and only had test negative results. But there were a number of people who had never actually received or gotten a COVID test, but still reported being COVID negative. And so that was 7.5% of the overall study. So roughly half of people in the community self-reported a negative COVID status. That means the other half self-reported being COVID positive at some point during the pandemic. And this is split again between whether people had a positive test result. So of all of the people in our community, during roughly 30% had a positive test result at some point during the COVID pandemic. 3% had never tested for COVID, but still reported being COVID positive. Some of these people reported that those reasons would have been having been in contact with someone who was living with COVID, or that they had a symptom profile that really matched onto it, but they weren't able to access tests. And you may remember earlier in the pandemic, access to self-testing was really non-existent. And even access to clinical testing was a challenge as well, particularly for certain communities and certain geographies. And then we also had people who had tested and only tested negative, but self-reported being COVID positive, again, for similar reasons that I just shared with the last group. So an overall picture here, I think, is that during testing wasn't necessarily accessible for everyone. And we saw a huge range in terms of some people who tested 10 or more times and other people who had never tested. This obviously relates also to job requirements during and access to testing. But I think it also shapes the fact that people have a sense of whether they have COVID or not, and that was split roughly 50-50. And some of those COVID positive self-reports are based on positive results of tests, but some are also based on clinicians telling an individual, based on what you've shared with me, you likely have COVID, or just knowing from their own symptom profile or contact with others, again, that they thought they had COVID. So that's the kind of self-report picture. And I just want to share a little bit more information around some of the COVID kind of self-report impacts. And so this first part is around COVID hospitalization. So amongst those who had COVID, during roughly 1 in 50 or 2% were hospitalized in a non-ICU context, and then an additional 0.7% in an intensive care unit. So that's roughly 3% of all of the folks who had COVID, who reported COVID in our community. When we think about the impact that this pandemic has had, though, not just on us as individuals, but also in terms of our networks, 15% of people had someone who was close to them who was hospitalized for COVID. And I think that speaks again to the kind of the impact that this pandemic can't just be understood in terms of our own individual experiences, and especially given how much isolation there was that was imposed in terms of COVID. I think thinking about this from a kind of network and a community point of view is so important. We also had about 1 in 10 participants report that someone close to them had died due to COVID. And I think, one of the things I reflected on a lot through the COVID pandemic, given my kind of training and coming up through the HIV response, is how we made space for and had ceremony for folks who passed away. How were people memorialized, how were people understood, how were families and loved ones cared for as people were passing away in relation to COVID. And so I think that's something that we'll be looking backwards at in terms of how this pandemic was affected. And obviously there are a huge difference in terms of how the HIV pandemic played out, who was impacted, how government responded, how stigma and discrimination was at play during that time, of course, compared with nowadays and COVID. But I think there are some things that are lessons that we should have learned better from during the HIV response that could have helped us do better in terms of supporting people in the some of those challenging times around COVID and losing someone who you care about. The second part of this slide is around vaccinations. And so we asked folks if they had ever been vaccinated against COVID-19. And there was really high vaccination uptake in our community. So 97.5% of participants reported having had at least one COVID-19 vaccine. And 2% reported no, and a very small portion of our study preferred not to answer this question. We know from some of the previous work and some of the preliminary work that we've dug into in terms of vaccinations, that people in our community were more likely to uptake COVID vaccines and were early adopters of this kind of public health intervention. And so I just include a little figure here from some work that was created using Sex Now survey findings from last year. And there's some new work that will be coming out of CBRC in the coming weeks around the COVID-19 vaccine data from our health, and really thinking about some of the boosters or follow-up shots as well. So more to come on vaccines. And then I also think it's really important for us to talk about post-COVID condition or long COVID. The name of this has shifted and changed over time. And so when we ran the survey, we asked, do you consider yourself to have, quote, long haul, end quote, COVID, or quote, long COVID? And so by this, we mean symptoms that persist beyond the initial infection. And so when we think about that, almost 1 in 5 participants said yes to self-reporting basically long COVID. Another 1 in 5 participants were unsure. And so only 3 out of 5 folks who had COVID didn't think that they had any kind of long COVID symptoms. So this is a pretty significant portion when we think about 1 in 5 or 2 in 5 having persisting impacts clinically in terms of managing COVID. We asked folks about, for those who had COVID, what were the top 5 self-reported symptoms of long COVID? And so when we think about those top 5, there was a long list of a number of different symptoms that really reflect, again, the diversity of ways in which people were directly impacted by COVID. But the most common ones that came up were fatigue, brain fog, depression and anxiety, a cough or persistent cough, and sleep disturbances. So I think this is going to be an area that despite some of the rhetoric and movements to kind of say that we're in a kind of post-COVID world now, we are still living with obviously acute infections around COVID still, but we're also going to be living with and managing these post-COVID condition realities for many years to come. And I think if our community is disproportionately impacted by this, it's going to be something that's really important for us to pay attention to in terms of advocacy and support for making sure that people within our community are served well and appropriately in terms of their needs for long haul COVID management. And then just lastly here, around COVID prevention practices. And so there was a lot of interest in public health about asking how often did people do this? Did you do these kinds of things? And we just know the reality of kind of 2 years of COVID, there was so much up and down in terms of the strength of public health measures that were in place, but also so much geographic variation in terms of the different ways in which individual provinces responded to and provided guidance on responding to COVID. And so running this study at a kind of national level was quite a challenge to think about how to ask about some of these things. But we also know that during our community is innovative and early adopters of a lot of preventive practices, and we do incredible harm reduction work in terms of thinking about substance use harms and sexual health. And so we wanted to give an opportunity for folks to reflect a little bit on some of the prevention practices they engaged in around COVID. And so we asked them to just provide a general rating around a few different kinds of prevention practices that we thought also were really important in terms of understanding the kind of social network, isolation and loneliness aspects of COVID. So 50% of people reported always having limited contact with people at higher risk. And so we can think about that both from an impact of losing some of the connections that matter to you, both as a person who might be worried about someone else being at higher risk, but also as a person who might be at higher risk yourself. 1 in 10 always avoided leaving the house or their home because they were at higher risk of COVID. Again, kind of thinking about our own self-risk assessment and the ways in which we edited our lives. 60% always self-isolated if they had symptoms. And I think this speaks to, again, during following public health guidance around self-isolation, but also to the realities of the fact that during being able to do that required equity and social capital, during being able to be supported, being able to have a job that might allow you to have sick days or sick benefits. There's a really important context to this. And I think connecting some of these things with the kind of economic module will be really powerful in terms of telling a more complete story around this. So that's a little bit around COVID prevention practices. And then this last slide here from the self-report on the surveys was really about what people were extremely or very concerned about in terms of the impact of COVID. And we kind of binned these into large categories of different aspects of health and wellness. So the top 2 concerns for people in the study were about the mental health or wellness of friends and family, as well as the physical health of friends and family. And so during more than any of people's concern for their own well-being, people in our community had stronger feelings around the concerns of the impact of COVID on those who are around them that they cared about, and whether that be mentally or physically. So we also asked people how concerned they were about impacts on their own mental health and wellness, and during 2/3 of people were very or extremely concerned about that. Half of folks were very concerned about their impact on their physical health and wellness. 1/4 of folks were concerned about the impact on their sex life, and 1 in 10 folks were very concerned about their spiritual or religious wellness. So again, I think really trying to think about a broad array of the ways in which a pandemic like COVID impacts us, not just in terms of infection on COVID, and not just in terms of during our physical health, but during a much more holistic understanding of what this pandemic has led to. Okay. So the next portion of this presentation is about the dry blood spot or DBS self-sampling process. So on the top right of the screen here, I show the kind of printed resource guide that we sent to people's homes or addresses of their choosing to send these self-collection kits. And so it provided a kind of step-by-step guide with some images about how to complete the dry blood spot process, and showed people, where to prick their finger, where to drop the drops of blood onto the card, and what kind of we were looking for in terms of filling out these circles on the cards. And so that's kind of the picture in the middle of this image there. And so, as I said, this was an optional piece. So of the 4,000 folks who completed the survey, about 44% requested that we send them a kit. And so what we found here when we think about some of the geographic differences is that people who were living in British Columbia, like myself, or people who were living in Nova Scotia, were more likely in the study to request a kit than would have been represented otherwise. And we saw below expected sampling in Quebec. And so we're curious a little bit about this. For me, I think about as my life during living here on Vancouver Island, on the southwest part of our province. We had a lot less access to testing than I know that my family and friends back in Ontario had, for example. And when we look at some of the population data around testing, we also see, that truth come forward in terms of the fact that there was a significant larger portion of people who were able to access testing and access testing more frequently in different parts of the country. And so to some extent, this may reflect that. And for me, I think this is one of the ways in which we also can provide some direct benefit back to research participants. So while this was optional, we gave people the chance to also receive their results And in addition to sampling just for COVID antibodies, we also gave people the option of screening for HIV, hepatitis C, and syphilis. And so if we were going to collect this blood from folks, we gave them a choice around the different kinds of infections they might want to have screened for, and then to receive that information back for themselves to make sure that they have the information they want about their health status, and being able to provide some peer support to participants in terms of linkage to information and care if needed for testing or treatment. So again, roughly 44% of survey participants requested a kit, and we were able to really successfully ship to basically all participants who requested one. There were a few that had addresses that we just couldn't resolve in terms of inconsistencies with Canada Post, and we did end up having to send about 55 replacement kits, which is totally fine. And so that just gives us a bit of an idea of, during running this kind of study again, with mail home DBS, if we want to use it again in the future, this is some information that can be helpful for us in terms of budget planning and logistics. And I just want to give a shout out to David Persicki on our team, who really managed this whole entire process logistically and so smoothly. So thank you, David, for everything. And then in terms of the kits returned, we actually got about 2/3 of the kits back. And we know that people have challenges sometimes in terms of just wanting to follow through with this protocol once they actually receive all of the information and see all of it. We know that some people also have a challenge in terms of getting during the blood to drip or run effectively onto the card. We did include a second lancet into the kit based on consultations, which is the device that's used to prick the finger, as a way to try and ameliorate some of those concerns and challenges. But in general, I think what it's good for us in terms of this return rate, and similar to what we were expecting based on our past experiences doing related work in the community. And so people receive their kit within about a week on average, which includes time for us to prep and ship those. And then in terms of the lab, there's a lot of folks who are interested in doing work around COVID, and this was provided in kind for us in terms of the study. And so a big shout out to our colleagues at the Public Health Agency of Canada for coordinating this for us. But it takes about, during an average of about 9 weeks to provide the testing results. And then we had peers on our team who provided those results back to our study participants who requested them. So that's a little bit about the process around the dry blood spots. And then I want to share some of the preliminary results we have for the results from the lab that we've received so far. And so this is based on 815 dry blood spot samples, and includes the samples that were received up to September 2022. And I think one really key thing here is that dry blood spots are not a common thing that people self-complete themselves. But 98.1% of the samples that we received back had sufficient sample to be able to test. And so I think this really shows the ability to support people being able to complete this kind of screening in their own home environment and provide a viable sample that can actually be screened for the things that we're looking for. And so I think that's a really huge takeaway and a huge success for our community in terms of demonstrating the viability of this method. And so now perhaps the things that people might be most excited for, but the actual laboratory-based tests. So you'll remember I shared some of the self-report pieces in terms of half of folks self-reporting feeling like they had COVID, and the other half reporting not feeling like they had COVID. When we actually looked at the antibodies for the COVID-19 virus, the SARS-CoV-2, what we found here is that 0.8% of the samples that we got back didn't have any COVID-19 antibodies. So that's less than 1% of the study participants. And so the vast majority of samples that we got back were positive for antibodies. And so what's important about that is that doesn't necessarily mean that 99% of the community had COVID-19. Because people can have antibodies really from two different ways. One, from getting a natural infection, so actually acquiring and getting COVID-19, or from a vaccine-induced immunity. And because we can test for different parts or different antibodies, we can think about, we can differentiate, I guess, between antibodies that come just from vaccine. And so that's roughly about 3/4 of the samples that we got back. And antibody patterns that indicate that someone likely had COVID-19, and that was about 1/4 of participants. So, of course, this is all, the preliminary work around this, but I think it tells us a few things. One of which is, generally, people really have antibodies around SARS-CoV-2 and COVID-19, whether those were naturally acquired or just related to vaccine. What's interesting in terms of some of these numbers, just in terms of some preliminary comparisons, is that roughly about a quarter of the sample had self-identified and tested positive for COVID-19. So there's some validity that we're seeing across the laboratory results with the self-report results, and we're going to want to dig into that a little bit more. I mean, understand, of course, that not everyone did these DBS self-home or mail home self-complete kits, and that we're basing this analysis today and sharing with you just some of the preliminary results. And so we are expecting more DBS results to come back and give us a more accurate reading or picture of this. So that's the kind of dry blood spot piece. I just want to kind of throw out there, I guess, some of the thinking that we're doing around the ways in which we can best support and advocate for our communities. And so our study in terms of our health is really focused on the full 2SLGBTQ plus community. But it doesn't give us a comparison for folks who are outside of our community. And that's often what sometimes people are quite interested in, and especially during public health and government, in terms of trying to understand the ways in which our communities need particular supports. And so there was at basically the same time almost as us running the Our Health study, a national representative study called the Canadian COVID Antibody and Health Survey. And this was a second cycle of this national study. And so what's interesting is that if we compare our results that we have using a dry blood spot and using a survey, which are two things that this study did as well, we'll be able to make some direct comparisons with the general Canadian population around this. There are some questions within this study that also relate to some of the things around doing our 2SLGBTQ communities. And so these are the questions that are asked in that survey. And you'll notice these questions are obviously very different than the questions that we ask. And I think this reflects a bit of the difference between taking a community-based approach and really centering and listening to the feedback we get from community around the diversity of ways in which people's sex, gender, and sexuality show up for them, and more traditional ways of measuring some of these things. I think it's great that we have a question about sexual orientation in this national study around COVID, because that's not something that we often ask about. But we also know that questions about sex and gender aren't necessarily reflective of the realities of people. And so I think it's data that we can access and use, but some of this is going to be also the ways in which we can contribute as a community-based research study to advancing the measures and the measurement of these kinds of factors and other work that's being done. And so that's something that we're going to look at and see whether we've got the feasibility to do. But I think it's really exciting to think about combining our data and putting it into the context of what's happening at a national level in terms of the rest of the country. So in terms of our kind of next steps around the study and mobilizing what we've learned, we take this kind of what's called a sex and gender-based analysis approach. And so this is really thinking about, the diversity of ways and factors that shape our well-being in our lives. And so we want to conduct stratified analyses, which means separating out these results. So what I presented today is really an overall picture of our community and the response to our health survey, but really disaggregating this or breaking it down by sex assigned at birth and gender identity, by sexual orientation, for Indigenous participants, by the different ethno-racial groups that we have in the study, for different age groups, by socioeconomic status, thinking about that geographic diversity, as well as regionally in terms of province and territory. So where we have sufficient during a number of participants, we're going to be working on providing this kind of stratified or broken down analysis. And as I said earlier, we're working with community advisors from each of these kinds of groups within our broader community to work on making sure that we're including the right kinds of questions and handling those data in appropriate ways. So that's something that's going to be coming more soon. We'll also be sharing our findings through a public data visualization dashboard. We've had some experience using this before at CBRC. So if you're familiar with the RStats dashboard, this is a tool that was created by Dr. Gifford Card, who was a postdoc when he created that, working with CBRC and SexNow data to really show what are some of those findings over time for key indicators around SexNow. And so we're taking some of those learnings from that tool, and we're going to create a brand new data visualization dashboard and tool that shows some of this information around COVID as relevant to our communities. And that will give people the opportunity to kind of democratize access to the information so that it's not always coming through us as the researchers. And so people can kind of ask their own questions of the data dashboard in terms of what they want to learn and understand in terms of the study. As I kind of talked about in terms of the sex and gender-based analysis, we'll be creating these kind of common language public reports, which are really meant to be quite broadly accessible to folks in the country around the main findings and main highlights of the study and what we recommend based on those. And then in order to kind of advance the broader evidence and the advocacy we can do within the research community, we'll work on providing open access manuscripts based on the study so that people can see both our process and our results, both of which I think have quite a bit to contribute to during policy and health service delivery. And lastly, we have a commitment to open science. And so we're really trying to work quite publicly about our protocol, our research tools, as well as we asked folks in the study if they would consent to data sharing. And so where people have provided their consent, we will contribute our data to kind of national efforts and international efforts around trying to combine COVID-19 information. And this really gives us an opportunity to make sure that 2SLGBTQ+ folks are well represented in some of those conversations, because we know that there are barriers and limitations to us participating in other research studies as well. And so that's kind of generally about how we're kind of strategically mobilizing knowledge. And I just wanted to finish with a few kind of high-level lessons learned. And some of these really relate to COVID-19, but a lot of this also just relates more broadly to thinking about CBRC's work and thinking more broadly about community-based research with our communities. And so what we learned is that deep community consultations take time, that they're important, but they also help ensure that we have better study accessibility and better diversity in our sample. That's really kind of builds on the disability justice frame of nothing about us without us, also very commonly evoked in the HIV response. And so this is really important in that it's critical for us to apply community-based research principles, especially when working with marginalized communities like our own. And I shared those kind of earlier, but just to highlight some of those key pieces during access, advancing social justice, thinking about community empowerment, and centering lived experience. Those are critical principles for doing work with our communities. The other thing the study will demonstrate is that during primary data collection is needed. We can't rely on secondary data, which means data collected for other purposes or by other people, without a primary lens of our community, because oftentimes there's not a sufficient or appropriate or the necessary indicators to understand the full range of the 2SLGBTQQIA+ community and our experiences. And so this study provides really rare insights into our community's experience with the COVID-19 pandemic. And so as I kind of talked about with some of the other nationally representative studies of the general population, we can think about how we compare our results to other things that are going on to try and understand and have a more robust conversation about policy impacts. And then lastly, I think just from a methods point of view, I really just want to highlight during the feasibility and the opportunity of community-based mailed DBS self-collection. This is highly acceptable to the community and highly successful in terms of providing samples that really allow us to have a biological evidence base behind the strong kind of narratives, anecdotes, and stories that we heard in terms of self-report impacts for COVID-19. And so combining these different kinds of evidence together gives us a stronger, cohesive story that is more defensible. And it also means that we can do more than just a one issue kind of assessment. And so dry blood spots allow us to look at more than just COVID-19 antibodies. And so in this case, we were able to give people that opportunity to also screen for HIV, Hep C, and syphilis, because those were all blood-based as well. And we know from the community that during impacts on sexual and reproductive health services, decreased access to testing were all realities. And so again, trying to think about how this study really provides a direct benefit back to participants and them being able to get the information that they want about their own bodies, I think is an incredible success of the work. And so again, I mean, huge thanks to the team for making that possible. And of course, to the Public Health Agency who did that testing for us. So I just want to thank all of our participants. Some of you might be out there today on the webinar, and so thank you for joining and listening back. This work is really only possible because of the time that people take out of their days to fill out a survey and answer a whole bunch of questions. And so for that, we're eternally grateful. The word wouldn't get out, the work wouldn't look the same without our partners at various agencies across the country. And so thank you for sharing the word about the study and helping with promotion, helping with recruitment, giving feedback on tools, et cetera. We've got a number of kind of collaborators and knowledge users that I just want to specifically name who will really help us in terms of thinking about the policy aspects of this work, in terms of PHAC and the LGBTQ Secretariat, as well as women and gender equality. And a special shout out to John Kim at the National Microbiology Lab, who really has been such a champion for us and our communities in terms of doing this work and bringing in that laboratory component. We have a huge academic team and a number of community advisors who also are a key part of this environment and ecosystem that makes all of this possible. And then, of course, to the research staff and trainees. Excuse me, I'm losing my voice, but we're at the end at least. Many thanks to all of the staff and trainees. It's been hard to do this work, asking us to delve deeply into COVID-19 while also living and managing it ourselves. And I just want to recognize your bravery for doing this work and for really carrying through and providing, I think, was such a beautiful study and such a great start in terms of doing this work with our full community. And then, of course, we wouldn't be able to do this without the funders who provide the actual resources for paying for all of the expenses that go for this. So huge acknowledgements all around, and very grateful to get to be here today to share with you a little bit about this study. That's the end for me, and I look forward to having some time for some questions. Okay, thank you so much for those who also shared some links around our research principles and about the RSATs dashboard in the chat. So the first question I have is around, was testing history self-reported or were data linked to lab results? So what I kind of tried to show here is a little bit of both. So we had the kind of self-report data that was related to how people kind of reported whether they felt themselves that they had COVID or not, and related to that to also whether they had been able to access testing and what the results of those tests were, if they were able to have testing. And then separately, the kind of information around what we learned from the lab process. And so for people self-reporting, that could include self-tests, that could include lab results that they would have had through clinical testing. So all of that was kind of included in the self-report side, but we didn't do direct linkages to people's test results in the clinical healthcare system. And so what we have in terms of the biological results are kind of based on the dry blood spot samples that people provided. I think the next step for us is to really think about combining those two sources of evidence and thinking through both who participated and was able to complete the dry blood spot process and how those results kind of shape each other. And so once we finish the full lab testing and have all of those results linked into everything else, then we'll be able to do that more kind of comparison piece. So thank you for that question. And Robert Ablanis, thanks so much for the question. Lovely to know that you're out there. It's good to see you. It's been a little while. And so Robert asks, regarding contact with people at higher risk, does any of the data directly or indirectly point to survey participants' awareness of WHICH people who are at higher risk, whether themselves or others? And I might have missed that. It might just be me and my presentation brain, or maybe it's my post-COVID brain, could be all of the above, but I'm not 100% sure what WHICH means right now. So if that could get typed into the chat, that would be super helpful for me. But I think for us, what we know around kind of that piece is that people were making their own oh, it's just WHICH. It's not an acronym. That's just my academic brain where we love to make acronyms about things. Thank you for that clarification. So awareness of which people are at higher risk, whether themselves or others. Yeah, so these questions were a little bit hard to tease apart because we didn't directly ask people if they themselves feel at risk. Again, because just from a notion of risk point of view, things changed so dramatically over the course of the pandemic. It was hard to think about asking a question that kind of got at that, and asking whether people acutely feel at risk at this moment in time of the survey didn't also feel as relevant. So we did ask people that kind of question about, did they feel like they limited their contact because they felt like they were at higher risk? And so in that part of the study, about 1 in 10 people had kind of indicated that they felt like they might be at risk themselves and therefore changed their behavior. So I think that gives us some picture in regards to, in regards to kind of like what that amount would be. And then in terms of other people, roughly half of people said that they really kind of limited what their contact was with people that they perceived to be at higher risk. And I think this is always such an interesting concept, right? Because I can think about, my grandmother, who's 100 years old, living in a care home, and how I feel about during her level of being at risk and how she may feel about that aren't necessarily always congruent. And so I think there's some place here where kind of opinions and perspectives can clash and collide. But people themselves were kind of indicating that during roughly half of the community made decisions about who else to see based on who they felt was at risk. And this is sometimes this kind of piece of, a bit of the challenge, I guess, of the self-perception aspects of risk, both for self, but also for others. But I think what's important out of that whole story is that it's also this piece that people were really thinking about that in our community and really thinking about both for themselves, but also for other people, the role that we play, both as as someone who might acquire COVID or someone that might also pass COVID. And so I think that's, yeah, thanks, Robert, for that question. Okay, the next question I have, I know you're moving towards the next step for sex and gender-based analysis plus. Were there any significant observations or data on the trans and gender diverse population so far? Great question. Thank you so much for that. We haven't done that stratification quite yet. And so there's no kind of data that I shared today that we're specifically looking amongst the trans community. What I think is great, Drew, and really kind of speaks to the strengths of the trans community is the proportion of our study that self-identify as trans is roughly 1 in 4. That gives us 1,000 participants basically, or were trans identified within our study. So there's a lot that we can look at within that. And of course, there's huge diversity within the trans community as well. And so really thinking about some of that gender diversity or sex-based diversity that exists, I think will be really important for telling some of those stories. We know that during surgical access varies based on gender-affirming surgeries, for example, and different kinds of surgeries were canceled or brought back on different phases as well. So I'm expecting that we will see some differences within the trans community, but also for the trans community as a whole potentially as well. And so, yeah, I think this is going to be a great piece. If you're interested in connecting more about that, I think reach out to us, Drew, and we're happy to kind of plug you into the kind of work in progress, looking specifically at the trans and gender diverse population. Okay, the next question I have is from the chat. And so this asks, my question as a support group facilitator is about how the evaporation of nightlife for a year and the subsequent division between people who still want to, quote, go out and those who had qualms about going out, about socializing in bars or clubs, show venues. How much does the queer relationship to nightlife emerge in the responses? It's a great question. So we definitely had some, tried to get at this a little bit in the community connections piece. And so we tried to understand how people shifted some of their participation in what we might call like queer specific life or queer culture. And so we do have some data that we can dig into around that. I think what's interesting around this also is how some of this varies across the country, both in terms of what was the baseline access to some of these things in terms of where you lived. And so I think about here in Victoria, just as an example, we had one kind of bar that was for our community before COVID. And during COVID, we had 2 new bars or pubs open up that were LGBTQ oriented. And so we actually experienced an increase in physical community space that was possible. And then to your question, Jordan, exactly, Jordan, that didn't mean that necessarily everyone was accessing it and that everyone felt comfortable with it. And so I think there is this kind of difficulty, or just, I guess, reality of the complexity of teasing apart where people live, how things shifted during COVID. And I think, I guess the main thing I would highlight is that it's not always a lost story. As you kind of saw from that overall self-report piece, there are a portion of the community that actually feel like some things improved for them over COVID. And so I think that's one of the things we want to kind of make sure that we attend to in our work is to not tell a single narrative of deficiency or, do you know what I mean? Or inequity, because we have incredible strengths and incredible resiliencies, and many in our communities have lived through other pandemics, are living through other pandemics still. And so I think we also want to kind of make sure that we create space in our work for those strengths as well. But I do know during my own life, there's still such a range of comfort engaging interpersonally. Also just to name, during the monkeypox pandemic, it's something that also shaped how people felt in terms of going out, connecting. And I know there was questions and so much uncertainty about what was going to be okay and what was going to not in those contexts. And so I don't need to tell anyone, but it's been quite a few years, right, that we've just lived through. And so I think that's something that we want to make sure we continue to reflect on and really think through, like, what did we do well about this? What did we not? And what do we need to make sure we do differently for whatever next challenge that will inevitably come to face with us. Okay, are there other questions? Or any other comments that people want to share in the chat or the Q&A feature on Zoom? All right, well, then I think we'll wrap up there for today. Thank you so much for coming out and spending time with me to listen about the study and some of the preliminary results. I'm glad people are excited about what else we can do with this study and these data, and we'll certainly be working on that. So if people are excited or want to engage more with us, please reach out. A huge shout out to the CBRC team broadly, both for this webinar today, but also just for all of the work over all of the years that make these things seem quite flawless and seem quite smooth, but I know how much goes into the back end of that. So thank you. And then to all of our participants and the folks in community that support us in this work. This really wouldn't be possible without you. And you're really the motivation for why we do this. So I'm glad to be able to be here today. Thank you so much for the time. And just a reminder to everyone that on March 23rd, we will have another webinar presenting about the Our Health study with a focus on the chronic health findings. Thanks so much.